This presentation is on hand and fingers clinical assessment. At the end of this presentation, you should be able to demonstrate a systematic subjective exam and demonstrate a systematic physical exam consisting of observations and inspection, joint range of motion testing, special orthopedic testing, and palpation. The first part of the presentation, at the end of this section, you should be able to demonstrate a systematic subjective examination. At the beginning of the semester, we did talk about general history questions you would ask during a clinical assessment. Here are some other questions to consider asking if the injury or chief complaint deals with the hands or the fingers. You should ask about sounds and sensations. Sounds because with the fingers, common injuries include ligament ruptures or dislocations and or fractures, in which case the patient may complain of hearing a pop or a crack. Sensations are important to ask. A lot of nerve entrapments or nerve irritation can cause altered sensation down into specific areas of the hand and fingers. For patients that have an injury that is of an insidious onset, it's important to ask about what type of daily activities and or occupation the patient is involved with. Some of these habitual movements and postures could contribute to their injury or condition. It's also important to ask about previous history, specifically that may result in contractures. More specifically, previous history of other injuries or medical conditions that could lead to contractures. Last but not least, there are some general health conditions that could manifest themselves in the joints of the hands and the fingers, such as rheumatoid arthritis or Raynaud's phenomenon. As a result, it is important to ask some of these additional history questions if the injury or condition involves the hand or the fingers. The next part of the presentation, we'll talk about a systematic physical exam. By the end of this section, you'll be able to demonstrate a systematic physical exam. The first piece, more specifically about observations and inspection. So things you would find or look for if the injury involves the hand and the fingers. Some observations to make: gross deformities, such as contractures or finger and hand postures, or deformities, obvious deformities as a result of an acute mechanism. Other things to look for are swelling, heat, altered function, redness, and pain or deformity, differences between the hands and palmar creases, and cuts and scars that could indicate other injuries and or surgeries. There are several hand postures and finger postures to be aware of that could indicate underlying issues. APAN is a condition where the median nerve has been inhibited, potentially because of an entrapment or a previous injury. When this happens, the muscles that are in the hand that are innervated by the median nerve, such as the thenar eminence, becomes weak and atrophies. As a result, the thumb ends up in a posture parallel with the rest of the fingers. In addition, because there's atrophy of the thenar muscles, the thumb is unable to flex or oppose. Claw hand results from ulnar and median nerve pathology. If the ulnar and median nerve cannot innervate the muscles in the hand and the fingers, then the metacarpal phalangeal joints will be unable to extend, and the proximal and distal interphalangeal joints will be unable to flex. So claw hand is a posture that results from ulnar and median nerve pathology. Bishop's or benediction deformity results from and entrapment and inhibition of the ulnar nerve. As a result, the hypothenar eminence, interossei, and medial to lumbricals atrophy. When this happens, the interphalangeal joints of the fourth and fifth fingers are stuck in a flexed position. Similarly, Dupuytren's contracture results in the same type of posture. There's a flexion contracture of the metacarpal phalangeal joint and interphalangeal joints of the fourth and fifth fingers, but this is a result of shortening and/or adhesion of the palmar fascia. This could result from a circulatory issue, from a previous fracture, and from other injuries. This table summarizes those for pathological hand and finger postures. In the first column, the name of the posture. The second column, or the subsequent columns, what use the therapist might see and what the cause is. Other observations used a therapist can look or can make involving the fingers include individual finger deformities that could be indicative of a fracture or a dislocation. Looking at the alignment of the fingernails could indicate a spiral fracture of the phalanx or the metacarpal. The next part of the presentation involves joint range of motion testing. For the hand and the fingers, at this point in the assessment, as a therapist, you are to perform active, passive, and resisted range of motion. Again, just like other regions or joints in the body, when you're testing range of motion, be mindful of your hand placements and the direction of the force you're placing on the patient. You always want to compare injured side and non-injured side to look for range of motion differences, differences in end feels, and differences in strength. For the metacarpal phalangeal joint of the thumb, test range of motion of flexion and extension, abduction and adduction, opposition and reposition. For the other metacarpal phalangeal joints, for digits 2 through 5, you'll be testing flexion and extension and abduction and adduction around the third digit. And last but not least, in testing active, passive, and resisted range of motion for the distal and proximal interphalangeal joints, you'll be testing flexion and extension only. The next part of the presentation summarizes the special tests that you can use to either confirm or rule out certain clinical presentations. The first test is called axial compression, whereby the metacarpal phalangeal joint is flexed and the therapist applies an axial compression towards the forearm at the metacarpal phalangeal joint. Pain or crepitus is a positive for a potential metacarpal phalangeal joint fracture. This slide describes a valgus and varus stress test, specifically at the interphalangeal joints. Just like other valgus and varus stress tests performed in different regions of the body, perform this test with a joint in extension. Stabilize the proximal phalanx with one hand, and then support the distal phalanx while providing a valgus and/or varus force through the interphalangeal joint line. Pain and/or laxity confirms a collateral ligament sprain, either an ulnar collateral or radiocollateral ligament sprain. Examples of fracture tests. Vibration is a fracture test where the examiner flicks the tip of the finger, or you can apply long bone axial load. So two different tests you can do if you suspect a finger fracture or a fracture of one of the phalanges. Pain and crepitus are your positive signs. And again, it's used to rule out or confirm finger fractures. The mallet finger test is a special test to confirm mallet finger. Stabilize the middle phalanx, and then instruct the patient to try to extend the distal interphalangeal joint. If they're unable to do so, it's probably because of mallet finger. The extensor tendon that's attached to the distal phalanx has been avulsed or ruptured. To confirm Jersey finger or a rupture of flexor digitorum profundus tendon, ask the patient to make a fist. If the tendon is avulsed, the patient will be unable to flex at the distal interphalangeal joint. And this is what the clenched fist would look like, confirming a Jersey finger. Finkelstein's test is a test that confirms and rules out de Quervain syndrome or a tenosynovitis of extensor pollicis brevis and abductor pollicis longus. Instruct the patient to tuck their thumb into their fist and have them ulnarly deviate. The therapist can apply an overpressure to put more force through the tendons with this test. Just a reminder that this particular position for the wrist is irritating on many people, so be careful of having a false positive. The last part of this presentation lists the different structures that you are required to be able to palpate during an assessment of the hand and or fingers. So please review all the structures that are on the next two slides and be familiar with where these structures are. So in conclusion, we hope that after listening to this presentation, you are able to demonstrate a systematic subjective exam and also demonstrate a systematic physical exam.